Hi, we're going to start the question and answer period. Well, a lot of questions, hopefully some answers. So we're going to start with this multiple part question that's going to be, I think, hopefully answered by me, and then we'll go to some of the others where I don't have to talk very much. So the first question is a more or less a specific question, but it has to do a lot with how we approach the diagnosis and how do we make a decision about treatment. And the question reads, for a period of about 6 months, I had a 1 centimeter mass in the liver that was described as quote-unquote vascular and appeared on CT and MRI scans. At the third follow-up scan, the mass was not detected. My doctor did not think this was a carcinoid tumor. Nothing was removed. No biopsy was done due to the risk of bleeding and the small size of the mass. Is it possible that sandostatin may have helped it disappear by the third scan? Can carcinoid tumors go away, or was this most likely not a carcinoid? I'll go to the other parts later. First, there's not quite enough information on this. By what this question says, it sounds like the working diagnosis for this doctor was carcinoid tumor, and he decided to treat the patient with sandostatin without a biopsy. So the first is the doctor decided not to do the biopsy based on the risk of bleeding and small size of the mass. First, I'd like to say that I don't think a 1 centimeter mass is small. I think that's a reasonably decent size to biopsy. Second, I don't know if this patient had symptoms or not. If this patient was asymptomatic and this mass was discovered incidentally on a scan looking for something else, then I don't know if I have enough rationale to even start any kind of treatment for this patient. Again, I don't know if there's any marker abnormalities as well. So one, if this is an assumed diagnosis without a biopsy of a carcinoid tumor that sounds like it was treated without a biopsy diagnosis, and I don't know if there are any markers to support or not support it. Now, the patient sounds like he or she was treated, and by the third scan, it disappeared. So can sandostatin do that? The answer is it can do that. Okay. Originally, sandostatin had an indication for treating symptoms and only symptoms. However, there were some recent publications that showed that sandostatin treatments can, in fact, at least halt the growth of tumor, if not shrink the tumor itself. So the answer is yes. Was this most likely not a carcinoid? I don't know, because I don't have enough information to answer that.
I'd just like to comment. From a radiologic standpoint, there are lesions, vascular lesions that we see in patients that are basically shunts, and hemangiomas. But they can go away. They're usually less than a centimeter, and we generally follow them for a period of about 2 years. But they will about a quarter of them will turn out to be something that we worry about, but if they stay less than that, some of them do go away. So that's one point. The other thing is that I think Dr. Lobuto made a very good comment in his talk, was that it's very important that the imaging be done properly. These tumors, for example, if it was a CAT scan and if the contrast injection was not done properly, something can be there, but it may not be detected because of the way that these are so rapidly enhancing that they can wash out and look like normal liver.
Right, and again, the key, another important point that was just mentioned is that vascular tumors may not be malignancies at all. That could be benign tumors as well. The next part of the question is, can sandostatin injections mask the levels of gastrin, serotonin, and CGA? And if so, how do you know that there is actually an effective response to sandostatin? And do you want to take that, Tom?
Yeah, say the question again, please. I'm sorry.
They want to know if this person wants to know if sandostatin can mask the levels of gastrin, serotonin, and CGA. And I think
The answer-
it actually treats it. but-
Yes, the answer is, now, if you look back at the amount of inhibition that you get from each of those hormones, it's about 50%. So someone who's on, as was alluded to by Dr. Gerstein this morning, who's been on a proton pump inhibitor and who's now starting to get neuroendocrine cell hyperplasia of the stomach lining, a good way to treat that, to keep the gastrin under control, is to use sandostatin. So when you say mask, it does. It inhibits. It binds to the same cell that's making gastrin or chromogranin A, and it inhibits. In general, the markers go down as much as 50%, maybe 60%. One of the hormones, pancreatic polypeptide, will go down 100% with sandostatin. But with the right dose, if you give higher doses, you can inhibit more. But that's the whole purpose, would be to turn down one of the hormones that might be causing growth. Gastrin can cause growth of the stomach lining, so it makes good sense to sometimes use sandostatin in that setting.
Okay, let's go on.
Yep.
And I think one of the important things to take from that question is we as doctors, we like to have a histologic diagnosis for treating patients as well.
Yeah.
To make an assumption is the first way down a path of one error after another. And you don't want to make errors. You want to be certain before you treat a patient with anything, because anything in the world has side effects, and you want to be absolutely sure of the diagnosis. Let's go on to the next question. This is for Dr. Labuti. After surgery to remove a tumor, how do you know if you need additional treatment, if there is no longer a tumor to compare to, whether it is getting larger or smaller?
Okay, so that's a great question. So at the moment, and I think this is a fair statement for neuroendocrine tumors, whether they be of pancreatic origin or carcinoids, we have very little data on the benefits of giving therapy as adjuvant therapy. And what adjuvant therapy means, very simply, is therapy added to surgery to prevent the tumor that was removed surgically from coming back. And there's very little, probably almost no data at the moment as to whether adding a therapy, whether it be sandostatin, an mTOR inhibitor like everolimus, a tyrosine kinase inhibitor like sunitinib, standard chemotherapy like temozolomide, Temodor, etc., adding that to surgical resection when all tumor has been removed, whether that's of any benefit above and beyond the surgery alone. Intuitively, as we develop more and more of these active agents, it makes sense knowing that patients have microscopic disease behind. That's why patients will live 125 months, but yet almost everybody is recurred by 5 years. We know they have microscopic disease when we do these big liver resections. Intuitively, it makes sense that adding something to the surgery would be of benefit, but we won't know that until we actually do the studies to see if it is, because not everything that's intuitive in medicine, unfortunately, ends up panning out. And as was just mentioned, none of these agents are without toxicity, and you want to balance that toxicity against efficacy. So the short answer is we don't know. We don't know after removing things surgically whether adding therapy to that is definitively going to be better than just waiting for the tumor to come back and then treating it once it's come back.
Okay, a couple of questions for Dr. Malloy. We'll start with some simple ones, I hope. Are bland embolizations still done?
Yes, bland embolizations are done. They're generally done by people at places where where, for example, radioembolization is not available either, because radioembolization, a very effective treatment and gaining popularity, does require a large coordination of medical professionals, radiation oncologists, physicists, interventional radiologists, surgeon oncologists, and some places just don't have that nucleus of people. So yes, bland embolization still are done, and they still have a significant degree of efficacy.
I have an interesting observation for Dr. Malloy. You know, we know that, and we discussed with the group here today, that GI tract tumors spread to the liver through the portal system. So these microscopic cancer cells go through the portal system, portal vein, and go into the liver. But you've also demonstrated that the majority of blood flow to these metastatic deposits after they become established come from the hepatic artery. So where is that switch? When does that blood flow switch, and how do you know when it switches, and how do you prove that?
That's an excellent question. We were very interested in this because you would think that, for example, there was actually at one point there was an interest in doing adjuvant treatment of portal vein infusion in patients that had a GI primary, thinking that you would pick these tumors up at the very earliest stage, but we couldn't develop criteria to follow the patients. The observation that has been made is that on a histologic and imaging basis, that by the time that the tumors become detectable by our current imaging standards, in other words, they're a couple millimeters or larger, they already have the majority, if not all, of their blood supply coming from the hepatic artery.
Okay. For Leanne, there was a question of the hype about wheatgrass and the benefits to the immune system. Do you have any comments on that?
My comment is I think that there are products that are going to be on the market that very little research has been done on, and that FDA approval may not be there. Foods that are high in nutrients are good across the board. I worry about, especially when they get into what you're just saying, these hypes, where it looks that if it's something that says it's a miracle or something's going to really be too good to be true, it usually is. Using a little of this in your diet's okay. I don't like to see people spend a lot of money and give a lot of hope into these unless there's research done. And without FDA approval on anything in the supplement area, it is not recommended. There also can be interference with nutrients and blood thinning effects of some of these. So depending on your situation, it's really caution anything in that area.
Okay, and there was a question about antioxidants. I want to address that first from a medical oncology point of view. Antioxidants, as we know, are free radical scavengers. Free radicals can cause and stimulate the growth of cancer. The problem with using antioxidants in patients that are undergoing active treatment for cancer is that most treatment for cancer generates free radicals at the local level, and that's what kills the cancer cells. So there's a difference in being on antioxidants before the diagnosis of cancer as opposed to being on antioxidants after the diagnosis is made. And you will get recommendations from radiation therapists or medical oncologists if you're on radiation therapy or chemotherapy not to be on antioxidants when you're on active treatment, because it may in fact interfere with the efficacy of those treatments. Okay, so here's another good question for Leanne. We know the recommendation has been made not to avoid certain foods before blood tests for carcinoid tumors, such as avocado, eggplant, tomato, walnuts, etc. Do these foods also exacerbate the symptoms of carcinoid cancers?
I think that that we do think that in high amounts, foods in the tryptophan area, and we talked about that a little bit about the tyramine, that are going to produce high serotonin amounts, definitely could cause some of your carcinoid syndrome, and that's why we take things down to smaller amounts. And but there's no research really at this time to back it. I think it's just a belief, and y'all may be able to
Well,
comment on it
I
too.
tell you, in clinical practice in my patients, if patients are having active symptoms, we try to ask those patients to avoid those foods, just as a generality. I'm not sure it makes a difference or not, but I think it's a reasonable advice.
I would just comment along those lines, because, the labs, most of the labs will tell you they want fasting levels of the markers, and we'll talk more about it. But many of the biomarkers are independent of nutrition. So you need to keep that in mind when you go in and worry if you've had a meal or you've eaten, and they say it has to be fasting. It really doesn't. There's only a couple hormones that are dependent, and what you look for on the assays are high numbers, not low numbers. So if anything, most of the assays won't see the nutrients that don't need, that are a problem. And if it's a gastrin or an insulin-secreting tumor, they're going to be very alarming levels if you eat or not. So especially if you come from long distances. And you don't worry about it. Just make sure you get the blood markers. Get the blood markers when you come in.
Question for Dr. Labudi. After a liver resection, can you still have liver chemo?
After a liver resection, can you still have liver chemo? By liver chemo, do you mean therapy directed to the liver?
I would imagine.
So the answer is yes. In terms of the liver perfusions that I referred to in my talk, for the operative liver perfusion, it depends on how much liver was previously resected, because we rely on enough normal liver to tolerate the treatment and carry the patient through acutely after the treatment. So for an open liver perfusion, it would depend on how much liver was resected as to whether the treatment would be safe to give. For the percutaneous hepatic perfusions and for embolizations, whether they be chemo or radioactive embolizations, there's a little bit more wiggle room. And as many folks know from reading your Greek mythology and Prometheus and the bird eating the liver and it growing back every day, the liver has tremendous regenerative capability. So after a resection of the liver, depending on how long ago the resection was, a lot of the liver will, was it Sisyphus? Did I get the wrong one? No, I think it's Prometheus. But anyway, the liver will regenerate. And so it's all a matter of how much residual liver is remaining as to how much therapy we can then give to it via one of these novel approaches.
Could I just ask a question too to Dr. Malloy? I'm curious to know, there's always a progression downside. I mean, with reported by Bloomston with HACE, that you can have a small percent of people that progress when you embolize. And I was wondering with the Y90 spheres, if you see the same incidence of contralateral lobe progression after you do one lobe with Y90, and how often do you see it?
Yeah, that's a great point, and I've heard that reported in several meetings I've attended to, and anecdotally I've seen it myself. For example, the phenomenon where you actually get a good response in the lobe that you treated, but the contralateral lobe actually seems to accelerate. I've had that happen to me anecdotally. I think it's very, very small fraction of patients, but yes, it does happen, and you do get there are some patients that get a change in their tumor biology as a result of this intervention, but I think it's very, very small.
We're going to go through a couple of questions quickly. One question asks this for the status of therapy with radionucleotide labeled peptides for metastatic NETs. And we're going to defer that question because Dr. Del Posan is going to be talking about that after lunch. A very quick answer from Dr. Malloy, please. After a Y90 treatment, how far away would you have a patient stay away from a pregnant coworker for everyone's safety and mental sanity?
Usually we say 3 days, and they should stay away from the right side of the patient. And those are very practical questions that we go over with every patient after the procedure. However, it should not. Most of the time, we make accommodations for patients that that don't have to alter their normal routine. I've had patients be on a transcontinental flight 2 days after treatment, so we can work it out.
Dr. Dapasano has some comment.
Just a quick comment on Y90. Y90 is what we call it a pure beta emitter. So majority of it is basically inside the tissue and it doesn't come outside. And this is why we have problem imaging it even. So the radiation exposure to people close to the patient are going to be almost zero. I mean, so there shouldn't be any, worrying about giving radiation to other people.
Okay. I have a couple of questions about chemotherapy that I'll try to address. One question is, once carcinoid starts affecting more than one or a few organs, is there any way to get this under control? So now we're talking about systemic therapy as opposed to directed local therapy, whether that be surgery or interventional radiation, interventional therapy. So the answer is yes, there is a ways to try to get that under control. Sandostatin can help, and then we have systemic therapy. There have been various chemotherapy agents, both intravenous and oral, that have been used over the years with moderate success. Some of the newer therapies, Dr. Warner started working with Temodar and Xeloda, an oral combination, and that seems to be very effective in midgut tumors that have spread. Is there a miracle? No, there's no miracle for this. We try it. We try those oral agents. We could try some IV agents. We've tried some of the newer drugs that we've mentioned here, the mTOR inhibitors, et cetera, but there's no real a miracle cure for that. But we can shrink the tumors, we can slow down the growth of the tumors, and we can certainly prolong life. Very important question that was asked, and again, this is something that I do have my opinions on. The question is, they've announced, and I don't know who they is, that there is now a shortage of some chemo drugs such as leucovorin. Do you foresee any problems with obtaining sandostatin? Will a generic sandostatin be available soon? And so the answer to that is very interesting. There have been a shortage of more than just leucovorin recently in cancer care. There's been a shortage of leucovorin, there's a shortage of 5-FU, there's a shortage of adriamycin, there's a shortage of Doxil, there's been a shortage of Taxol and generic Taxol. And most of these are generic drugs. And what's happened is, as you know, when drugs come off patent and they become manufactured in a generic form, the companies that manufacture generic form have to apply to the FDA and get their manufacturing process approved. The formulation may be identical, the manufacturing process still has to be inspected and approved by the FDA. What I have heard, and maybe Tom knows a little bit more, but what I've heard is that the FDA has been very slow in inspecting these companies, and they have also decertified some of these companies, and therefore that's led to shortages worldwide of some of these more common drugs that it's really been a real thorn in our attempt to treat patients. And I've actually experienced some of these shortages for my patients.
Yeah, and octreotide is in that group because the subcutaneous form can be very difficult to get.
That's right. We're not getting samples on that at all.
You're not getting samples.
Right.
The LAR is working, and lanreotide's in coming in fast, but it's not a short-acting form. The only available is the octreotide acetate.
Right. So right now, because sandostatin LAR is not generic, it's manufactured in one plant, I don't really foresee a problem with that. Will a generic be available soon? Probably not. Yeah, I don't think it's coming off patent anywhere soon.
10 years.
So that takes care of that. Does sandostatin cause an increase in facial hair, or does it cause hair loss? You want to comment on that, Tom?
Boy,
There are side effects to sandostatin.
there are the side effects, and Leanne alluded to them. The most prominent one is obviously sludge of the gallbladder, and the LAR form is bound to cause sludge in the gallbladder. Sometimes cholecystitis. The incidence is about, I think, over time, about up to 20%. The second most common thing we see is the fat malabsorption, also alluded to, and for which enzyme replacement is very wise to do with the LAR form. Usually the sub-Q is not as dramatic because you have fluctuations in the levels when you take the sub-Q. I'm not aware of hirsutism, and there's been I think I heard the number 5 million patient shots or uses, summary of side effects and things like that. Nor am I aware of hair loss. One of the things that might be associated with the alopecia or hair loss is that over time with LAR you get a secondary hypothyroidism. And the test to measure that is a free T3. And that will give you hair loss with hypothyroidism. And I have seen that frequently. So you want to be aware that your thyroid can go down over time with the long-acting repeatable form.
Did you mention hyperglycemia as well?
Hyperglycemia, excuse me, thank you. Hyperglycemia is transient. Now, if you look hardcore at hemoglobin A1Cs, which is the average 10-week blood sugar average, I have yet to see a non-diabetic or non-prone glucose intolerant patient get a higher hemoglobin A1C than 6.2 or 3 when the normal is up to 5.9. So there is a glucose intolerance guaranteed of sorts. But only when you have the underlying diabetes does it kick it higher. Otherwise, you do get a slight glucose, and it usually doesn't seem to remit. It's with the LAR, it stays. You get more hyper than hypo, but sometimes you can get hypoglycemia with a large. You can get a low blood sugar for 24 hours after the long-acting repeatable, and some of the extreme fatigue that you get is because you're antagonizing one of the hormones and letting insulin win. So with some of you folks may have had with a depot shot, you may have experienced a real fatigue with the shot, and that happens because of the massive levels of octreotide in the first 24 hours of the long-acting repeatable shot. But more often than not, chronically, you see just what Dr. Gerstein said, and that is hyperglycemia.
And those patients who have a pre-existing diabetes, and you know who you are in the last row there, whose sugars go out of control when they're on sandostatin, need to get that under control.
Yes.
Okay. Last, and we're going to wind up, one comment and then a question for Leanne. Does the disease deplete vitamins D, B12, et cetera? The disease itself may not, malabsorption will certainly contribute to it, but I caution patients not to self-supplement vitamins D, E, A, and K, the fat-soluble vitamins. Those should only be supplemented under supervision because being fat-soluble, they will cause serious side effects. B12, I'm one of those doctors who could care less. You could load up on B12 all you want. Vitamin C, you could load up on all you want. They don't bother me. Water-soluble vitamins don't bother me. But D, E, A, and K, very, very important. And the last comment for Leanne, patients want to know where they can get copies of some of the diet plans, the FODMAP, the low tyrosine, lactose, gluten-free. Are they available somewhere that they can copies, and how do they know which one they need?
Most of the diets can be just Googled. As easy as just putting in low tyramine and Google it. Most of them will come up under either a Mayo Clinic. Use the sites that a hospital or a medical center has. That 9 times out of 10, they're really going to be good. That's where I'll get worried about some of the Googling. But many of these, I try to keep on my website down, Ochsner Kenner website, and I can get that for you. But most big hospital sites will have it on their web page. If not, most dietitians have them, and I do believe that you may need some referral to get into a dietitian, but they can provide these for you also. Anything that I've talked about today that you want to have more information on, if you'll email me, I'll have some cards and stuff. I'll be glad to get them to you. just, and many of them, if not, we'll put them on the CCAN site.
Great. All right, that'll conclude our question and answer. Let's go eat.
Okay, let's go.